Thanks very much, everyone, for being here. So this paper is literally about what we can learn from babies born during health worker strikes. And the idea here is to capture, to measure in some way the benefits or lack of benefits of the standard of care in hospitals in Kenya. Okay, and so the idea is to use, no, it's not working. The idea is to use the incidence of strikes as sort of these shocks to the availability of care to then see what happens when care is removed. So in order to do this, we basically collected our own data set of health worker strikes across sub-Saharan Africa. And this is kind of a typical article that got us interested in this project in the first place. And it's going to have, this article, just in a few lines, has a lot of the themes that we're going to see today. So first is this association between a health worker strike and deaths or severe health outcomes. So here we see babies dies, a maternity hospital strike continues. This turns out to be one of the largest maternity hospitals in Nairobi and in Kenya. And so we have the deaths, but we also have something else interesting here, which is not always the case, but sometimes the case. In this case, the strike occurs and the whole hospital is closed. Sometimes it'll be that it's nurses that are striking, or it's doctors that are striking, or somehow they're not closing the hospital altogether, but they're removing some of the services, not working full hours. The other thing that goes on that's important to note is that expectant women end up going to different hospitals. Okay, so it's not always the case that the hospital closes and people don't have any care at all, but it may be that they're going to some hospital that's somehow less preferred. Okay, or the services are worse, or maybe it's farther away, and so they don't get follow-up care. So these are some of the things that may be going on. So in the collection of this data on strikes, we found out, kind of sort of surprising, that there's a huge number of health worker strikes going on in sub-Saharan Africa. So over the last 15 or so years, we found 620 strikes across around 40 countries. And so they're quite frequent. I mean, there's some variation there. Kenya is one of the countries that has the largest number of, second largest number of strikes. Nigeria is first, which has a huge number. But most countries in sub-Saharan Africa have seen a health worker strike in the last 10 years or so. And so as I said, these strikes often are associated in the popular press with severe health outcomes, and it's not always childbirth. So AIDS patients, generic cost lives, AIDS patients are hit hard by a strike. A man dies after being kicked out of a hospital, presumably because he was not able to get some care that he needed to stay there. And typically, as you might imagine, these strikes are the outcome of labor disputes of one kind or another. Oh, works. So, as I said at the outset, we're also interested in these strikes because we think this can shed some light on the value of standard care when it's removed. And so in resource-poor settings, it's not exactly obvious that there's going to be positive effects of hospitals. So, Paul Farmer, for example, has kind of linked the spread of Ebola to the poor quality of care in developing countries or in West Africa. Jishnu Das has this blog post that's kind of based on a series of research studies that he's conducted in India, where he questions whether the idea of getting more women to give birth in hospitals is not actually causing more deaths. Because potentially the hospitals have misaligned incentives. So he was looking at a program that was encouraging women to give births in hospitals, and what the doctors were doing was doing more cesarean sections so they can see more patients, and this was causing worse health outcomes for women. So in addition to those things, there's lots of research showing that doctors and nurses aren't present a lot of the time, and that when they are present, they may have very low knowledge or exert very low effort in terms of helping people. And this low knowledge and low effort can be large enough to cause actual harm. Okay? But of course, it's difficult to measure what the quality of these services is and what benefits there are. It's morally, and ethically difficult to withhold health care. And obviously expensive to provide it all, to a large group of people. So the idea is to use these health worker strikes to see what happens when this care is removed. So we're going to look at the effects of removing this health care on babies in Kenya. First, because as you can see, the rates of infant mortality, but also mother mortality, are an order of magnitude or greater in developed, sub-Saharan Africa relative to developed countries. So there's scope here for maybe small changes in the provision of care to have large effects on outcomes. And Kenya is sort of typical of sub-Saharan African countries in these outcomes. And so we're also focusing on births because we think it's arguably kind of exogenous variation. The timing of strikes is arguably exogenous to the timing of conception or childbirth, right? So it could be that, for example, you're sick with some kind of other problem and you know there's a strike going on, and so you delay care until later on. But with a childbirth, you really can't delay it. You have to give birth at that moment, and if there's a strike going on, that's sort of random to you. So we can observe kind of the universe of people who should be or who had to deliver at a particular moment in time, and that's very clearly defined who needed care at that moment. And then we can kind of match that with strikes information and measure the impact of these strikes on health outcomes. And we can test this assumption of exogeneity by looking at characteristics of mothers who gave birth to a child when there was a strike versus when there wasn't a strike, and see whether or not there's something different about those mothers, and we're going to find that there's not. Okay, so there's this idea that these strikes are exogenous with respect to the timing of births. Yep.
These strikes are union organized?
Good question. So sometimes. Okay, so there's a lot of variation in the type of strikes that goes on. So as I mentioned before, sometimes it's nurses, sometimes it's doctors, sometimes it's union organized, which case often it's across the country. But there's many often strikes that are within a specific hospital. So like the article at the beginning that I showed you with the Pumwani Maternity Hospital, that was just at that hospital and had to do with the union. So we're actually going to exploit local strikes. So strikes within states, basically, or counties of Kenya, not national strikes. So there's going to be variation in the timing of strike over time and also geographically. Some of the strikes are these unionized ones. Those are usually the national ones, and we're going to kind of ignore those. Yeah.
So, sorry, are they kind of random strikes, like they are not predictable, and what happens during these strikes? So like everybody stops working on, still the hospital has to provide a minimum amount of service.
So there's variation there too. Here we don't have enough, in Kenya we're not going to have enough strikes to separately analyze when the hospital was totally closed versus when it was partially open. It depends. So like the Pumwani strike, the hospital is completely closed. But in other cases, they're providing emergency services. In terms of whether they're predictable, they may be predictable in the short run. Sometimes they're linked to, and this is kind of other research that we're trying to look into, kind of the dynamics of these strikes. Sometimes they're linked to elections, but they're not, you don't see them only in election years or around election years. They're sort of smooth. But from the point of view of the mother, she would have to know 9 months in advance that there's going to be a strike. So to the extent that they're predictable, that far in advance, I think plausibly they're not. But it could be the case that the week before you're set to deliver, there's a strike, and so you make alternative plans at that moment. Yeah.
Is the induction of birth common?
Not common. And even cesarean sections was something we were interested in, given the literature on these kind of negative effects of giving birth into a hospital. We looked at that, but they're relatively uncommon as well, becoming more common. But right, the doctors don't typically set dates. I'm thinking very poor setting, woman is pregnant, and boom, I've got to go somewhere.
Sorry, just
yeah.
the last clarification on your identification. So it's true that it's exogenous, conditional on the month of conception, but it's also true that, if I'm living in a country where it's quite well known that there are strikes all over and continuously,
right.
in the healthcare system, maybe I will have a plan B, notwithstanding the fact that it's a week before.
Absolutely.
So, maybe you end up with having a selection about the women who do not have any alternatives, and so they are the poorest, the weakest.
Yeah.
This kind of affect your outcome.
Yeah, absolutely. So it's in particular that kind of idea that made us think about actually not looking at Nigeria first. Because in Nigeria, the strikes are so frequent that it's almost like that's the status quo, that there's going to be a strike at a hospital. And so in Kenya, although it has the second largest number of strikes that we've found so far in sub-Saharan Africa, they're not so frequent that you would think, a typical mother is saying to themselves, an expectation there should be a strike, or I should have this plan B. But it's still a valid point. There could be certain types of mothers who are planning that way. we're going to see that the people who are affected most are people who typically used hospitals, which are more educated women and women who live closer to hospitals. But it's going to be relative to those same women who give birth not during a strike, right? So there could be selection in the type of people who avoid hospitals or who have this plan B. There could be that type of, those women could be different, but the effects we're measuring here are relative to those very same women in some sense, but just who happen to give birth a week before. So as I said, there's two ways this could go. Strikes could be harmful, and they could also benefit. And so you can all kind of, I think, imagine without having to read all this stuff that there's many ways that a strike could be harmful. The woman either gets turned away, or she shows up and there's less good quality at that particular hospital. It's only working with a skeleton crew or emergency level services. Or the health workers could just be there and disgruntled and not really interested in providing as much effort as they typically would. Or the hospital could just be closed completely and the woman delivers either at home or in a worse facility, and then this gives rise to complications that wouldn't have occurred. The strike could be beneficial, right, particularly if the health facility is very bad, right? And the women in this case would have to be somewhat unsophisticated about their knowledge about this, right? So this, in a way, goes to thinking about selection again. I mean, you would have to have this, for this to be true, women would have to kind of not know that hospitals potentially have these major problems. They might not, know what an ideal hospital looks like in some sense. We see lots of women giving birth in health facilities, and the government certainly encourages that women give birth in facilities and have trained doctors and nurses present at the time of birth. And so you could, think of an argument where women aren't as sophisticated as one would hope about the quality of the health facility. And so in this case, if a strike occurs and a woman ends up not going to this facility where conditions are so bad, she may end up not getting infected with some other thing and having fewer complications. And then, as we discussed earlier, there's this possibility of overused interventions like cesarean sections where that increase risks for women that they otherwise wouldn't have if they gave birth at home instead. So we take advantage of this timing of the strikes. We combine this health worker strikes that we collected with basically demographic and health survey data, which is self-reported results of birth outcomes, so the timing of the birth, whether the child's alive or not, where the woman went to deliver the child, vaccination rates. And then we're going to be estimating this is basically kind of like a large multiple difference and difference type setup where we have these fixed effects for year and month of birth and also place of birth. So again, the identification is going to be coming from basically the same woman at the same place, but who gave birth within a month of each other when there wasn't a strike. So what we find is that strikes reduce the likelihood of child survival.
Sorry.
Yeah.
Are they long, the strikes, or are they very concentrated, because I'm thinking of whether this could not only affect birth outcomes, but also prenatal care.
Exactly. So that's a great question. So I'll show you in a second, the strikes are relatively short, about a week on average, but there's variation there. And that's something that we're interested in too, is whether or not, you may not be born during a strike, but in the weeks after. But then thinking about prenatal care, like for example, vaccines.
Yeah.
You need a vaccine in a certain period of time. Let's say it's 6 weeks after you're born. There's a strike during that week, but you can delay that vaccine. You can get it the week after. Whereas the birth outcome, we should expect sharper effects there because.
No, but I'm thinking before giving birth.
And before, I'm sorry, prenatal, right? So before giving birth, same issue, right? I need to make X number of appointments and be checked by the doctor. Unless there's something going wrong, it might be okay if I go the week after. Right, so we might still expect, but we're going to look for where these effects are going to be found.
But maybe if I miss my appointment because there's a strike, I don't do it anymore.
That could be. Yep, exactly. Or I infer something negative signal about the hospital and I don't, right? Exactly. So we're going to look at that. So But basically, the main results are that we find that the strikes reduce the likelihood of child survival at 1 month, 6 months, up to 5 years. Among survivors, we see suggestive evidence that it reduces the health in terms of height for age and weight for age. Interestingly, we don't see any change in the likelihood of facility births, like so whether a woman gives birth in a hospital or not. So there's this idea of switching hospitals. We see something there, but I'll talk about in a minute. But we do see large reductions in early life interventions, particularly vaccines. Right? So if you're born during a strike, you're much less likely to get the vaccines that there's a vaccine you get right at birth, and then a couple of vaccines you get at 6 weeks after birth. You're much less likely to get those vaccines. And so we're thinking that potentially, it's suggestive evidence that what's going on here is that the strike happens and a woman may go to a different hospital than her kind of preferred hospital, and then she doesn't get this follow-on care, and that's potentially what's contributing to these deaths. And there's also sort of immediate deaths, with complications at childbirth. The effects are highly concentrated among people who are most likely to use facilities, which sort of is intuitive. So you think of a woman who's living in a rural area who typically doesn't go to a hospital to deliver. If there's a strike going on in her state, it doesn't really affect what happens to her. And so it turns out that women who have more than primary schooling are much more likely to use a hospital, and women, obviously, who live near facilities are much more likely to deliver in a hospital. And we see that those are where the effects are being driven. And then we have this separate analysis with a data set that comes from 2 slums in Nairobi that corroborates the findings on the mortality issue. So, and the slums data is a little bit nicer than the DHS data in that we know the exact date of birth of someone and the exact date of death, whereas the DHS, we just know the month of birth and month of death, and so there's a possibility for measurement error, particularly if a strike is only a few days long. So we get a real nice match there. So this was kind of the worst part of this project, was collecting the data on the strike. So we went through digital archives of newspapers from sub-Saharan Africa. There's some online collections, but then also going to the websites of individual newspapers in different countries and kind of searching for the words health worker, doctor, nurse, strike. And we collected all this information. And so for each, we know the start and end date, although I should put an asterisk on the end date. Sometimes our end dates are a little bit fuzzier than we'd like. Usually the newspaper will announce a strike as starting or as continuing, but they won't have an article about when it's ended. So we're still working on cleaning that up. So there might be some measurement error in the terms of how long these strikes are. We know the location. We know, is it a particular hospital? Which county is it in or state? The actor, was it a union? Was it the nurses or doctors in particular, or both? And what the grievance was. So it turns out that most of these strikes are local. Okay, so in other words, they're happening at a particular hospital or within a subnational unit of the country. And they can be private hospitals or public hospitals. There's variation in there. And as you might expect, the most common grievance is going to be over salaries. So in Kenya, for example, 62% of people of the article cited salary or payment issues, and another 15% mentioned salary payment plus some other issue, like the quality of the hospital isn't good. So here is a look at just the kind of frequency of strikes. This is all the sub-Saharan African countries, and this is Kenya. So there's one strike going on here. I think this is month by month, and it looks like they seem to be increasing. We don't try to push that too far because the digital archives sort of become more sparse as you go back here. So we might just be missing some. But there do seem to be lots of strikes going on, at least in sub-Saharan Africa, and Kenya has its fair share at different points of time. They had elections in 2007, which is somewhere in here, and 2013, which is around here. So it's not exactly the case that these are tied to elections coming up. Okay, so in Kenya, the question was, so Kenya is sort of typical. Most of the strikes are not national strikes. A lot of them, of all the non-national strikes, half of them are in Nairobi and half are in these outside counties around the country. And the typical length of a strike is a week, but as you can see, there's a lot of variation there. So
Are the strikes in the month just sort of before the wage is renegotiated, or?
So, I mean, so the wages, in some sense, the wage is negotiated at one point in time, and then it exists, and then people may strike over.
But there is not like a month in which normally wages go up.
No.
Every year by to cope with inflation or whatever.
No, no. And typically, what happens is that, for example, there's this is something that we're still exploring more. But there seems to be this pattern that they'll strike and severely strike in some sense and close the hospitals down and cause a negotiation. The government will finally relent and say, okay, we'll give you X amount. They go back to work, and then the government never fulfills the promise. And then at some point they get fed up and they strike again. So that's actually going on right now. There was this set of strikes in Pomwani Maternity Hospital in 2013. They negotiated a salary, and in 2017 or late 2016, and then spread over into the new year, they've been striking again over the same issue. Like, hey, what happened? Yeah.
Do you know how many hospitals are affected by these strikes? Because this might be driven by 2 hospitals.
Right. Right, so it's more than 2, and in the paper we kind of list all the different strikes. I don't remember it now. What's nice is in the slums data that I get to later, it's another actually nice aspect about it. We have these 2 kind of very high density urban slums that are close to actually a number of hospitals, but in particular some striking hospitals. And so we know exactly, it's a few hospitals that are going on strike and not going on strike, but we can see. Okay. All right, so yeah, so to get coverage over all this period of strikes, we used demographic and health surveys of women from several different periods. From 3 different waves of it. And we get the complete birth history and mortality for all the children in the samples. There's 90,000 of those kids. For kids under 5, we get extra information on the place of birth, whether a doctor was present, these broad health measures in terms of height and weight for age, and vaccination records. And so we're going to match this to the strikes data using the county and the birth month and year. So there's some problems here. The county is the current residence of the mother, so to the extent that she moved, we're going to mislabel people in terms of whether they were affected or not by a strike. Birth month, we don't know the day of birth from the DHS data, and so there's going to be some misclassification here. But both of these we think would bias our estimates towards 0. We're going to have people labeled as treated when they're actually not treated, and vice versa. All right, some description of the sample. So it's only true that about half of the births actually take place in a health facility at any given time. But there's a large difference in this in terms of how educated the mother is. So if you have more than primary schooling, 64% of you will give birth in a hospital, whereas for people with less than primary schooling, it's only around 30%. And same kind of basic difference in terms of location. You might think these are kind of correlated. Women with more education are more often found in urban areas. Among the facility births, so women who deliver in a hospital or health facility, only 36% have a doctor present, but there could be a nurse or a trained birth attendant who's there. So it's not that there's nobody there, but it's not always the case there's a doctor. C-sections, 13%, and that's actually something that's been increasing. But there's not so many of those. Very few people have a C-section outside of a facility. Height and weight, as you might imagine, are low relative to international standards, but is better for more educated mothers and women who are closer to a health facility. Vaccination rates are actually very high, well, relatively high at 90% typically for most vaccines. But again, the same pattern. People who live close to a hospital or who have more education have greater rates of vaccinations. So we have this terrible statistic on infant mortality, 50 out of 1,000 live births, which again is kind of an order of magnitude larger than in developed countries. With some variation here, more educated women have less likely to have their children die within the first month. than less educated women, but we don't see much difference in terms of location, so how far you are from a health facility. And then, as I said, there's this kind of strong correlation between more educated women and location. So more educated women are more likely to be in urban settings, to have electricity and so forth. And women who are closer to facilities are better off. They have more schooling, again, so repeat, and are sort of wealthier and have fewer children. So here's this question about when should strikes matter. So one of the claims here is that at birth, but also potentially before birth and after birth, right? So there's this issue of prenatal care and antenatal care, but there's also, if a strike happens before the birth and it's resolved, I might think that the facility has gotten better. Somehow the nurses and doctors are more happy, or they're getting paid better, so they're spending less time at side businesses trying to make money, and that they're there. Or it could go the other way around. I might infer some negative signal about the hospital. Or there might be actually something negative about the hospital. And after birth, if there's a strike going on, so there's this idea that people could be predicting whether or not there's a strike coming. They hear around that there's disgruntlement, and so then they avoid this hospital. So to look at sort of the effects of the timing around the birth of a strike on mortality, what we do is we put mortality on the left-hand side, and we have basically an indicator variable here for whether the strike occurred in your month of birth or any of the 12 months preceding your birth and the 12 months after your birth. So the idea is to look at to see, is there any effect of a strike occurring 1 month before your birth on mortality, or 6 months before your birth, or 7 months after your birth. Okay, so these are all going to be relative to women who give birth, outside of a year of a strike. And then we include county, birth year, and birth month fixed effects, and also survey fixed effects. So this is those coefficients on those dummies, the 12 before, the 12 kind of leads, and the 12 lags, the position of a strike relative to your birth. 0 would be that there was a strike in the month that you were born. 1 would be that there's a strike in the month after you were born. -1, there was a strike in the month before you were born. And so they're sort of all over the place. We don't have a lot of power to pick this stuff up, but what we see is in the month that there's a strike in the month that you're born, you're more likely to have died, and then no real clear pattern on the effects of these strikes before and after.
So in month 2, is there any very important vaccine that they should take, or?
In month 2, so 6 weeks, that would be month 2. There's 2 vaccines that they're supposed to have. But again, we could do this same picture for vaccines, and it's even more of a mush, because they could go the week after.
Right.
Yeah.
But there seems to be some.
Yeah, there seems to be, but you'll see. I'm going to show 2 more pictures like this. There's some bouncing around on both sides that doesn't seem to totally make sense. Like, why month 2 versus? I've looked at this a lot and I wish that they were all kind of. Yeah, so same with -9 months. I mean, it almost seems like there's some benefit. That would be when you're about to conceive this child. So we're going to split this now, thinking about who's most likely to be affected. And as I said, people who have high levels of education, more than primary schooling, are much more likely to deliver in a facility than women who don't. And so we're going to run this regression, but separately for women with more than primary schooling and women who have less than primary schooling. And so here we see that same picture again, and things are sort of smoother around. And then if we look at the women with less than primary schooling, there's some things here, but it's kind of overall this kind of mush, which sort of is intuitive. Women who use the hospitals are more likely to be affected by them than women who don't.
Is there a differential effect on who delivers in hospital by education and strike? Because you might think the more educated are the ones that read the newspaper and so finds out about the strike and plans ahead, or does something.
Right. So this kind of goes back to the earlier thing. If I'm more educated, I might have this knowledge ahead of time. There's a strike brewing, exactly, and I might make up this plan B. But I'm going to be comparing that person to the same type of person, a more educated woman who gave birth when there wasn't a strike. And so what I'm comparing in some sense is plan A versus plan B, which is what I'm after, right? Is this idea of they might have these plan Bs. Even at home is a plan B.
No,
yeah.
that the most educated is probably more able to come up with a better plan B. So
Right, right, right. I mean, so the people who kind of get lost in this story a little bit are the less educated who need to go to a hospital. So the people who are less educated don't go to hospitals. Their selection, there's going to be, I think, stronger selection there, and the types that end up going to hospitals, they have some things going wrong in some sense, and that's why they go. And we'll see that they don't, there is some movement, they don't give birth in a hospital. So there's a small fraction of women who are less educated who give birth in a hospital. When there's a strike, that goes down by a lot, so they're getting turned away. There's not enough of them to pick up any mortality effect, but they're sort of lost in this story, right? So I think it's not exactly what you asked, but it reminds me of that. Yeah. Sorry.
Is it possible to use mother fixed effects?
Yeah, so we do that as an extension, and we get the same basic results. Yeah.
Can you look at
So yeah, exactly. That's a good point. I should mention this. Even within mother, we see this pattern. Yeah.
Can you look at mortality of the mothers?
So that's an extension that we haven't done yet, but that we're interested in. Absolutely. Okay, so we're going to use these two levels of variation. First, whether there was a strike in the month that you were born, and again, county year and birth month fixed effects, so that we're kind of excluding this story that there's something going on over time, like strikes happen to occur in September, and that's when mortality is the highest. Well, we have month fixed effects, but we also have year fixed effects to wipe that away. Or it was an election year and there was more chaos in hospitals or something else going on. We're going to be controlling for that. And then we'll estimate separately for the high educated, low educated women. And instead of doing, low educated times whether there was a strike or high educated times, so we just do it separately so it's easier to read the coefficients. And so the key identifying assumption here is that this timing of strikes and mothers' decision to conceive a child is exogenous. And so we can check that quickly, sort of like a randomization check to see whether or not there's something different about women who gave birth to a child during a strike versus not. And panel A is just group them all the women together, and panel B is looking at the high educated women separately from the low educated women. Basically, we don't see any differences between them, I think you would expect. So this is the first set of results. There's a lot to look at here. Mainly, I think we just focus on panel A and panel B. And I'll describe in a second what these lower panels do. So the panel A is just, was there a strike during the month that you gave birth to a child? And panel B is splitting by whether you're a woman with more than primary schooling versus you're a woman with less than primary schooling. And so we see that child died as the first column, as this is whether their child has died by the time they should have reached 5 years of age. And then we look at the first month, 6 months, and first year. And so across the board, there seems to be this effect that when there's a strike going on, even though, well, I'll get to that in a second. When there's a strike going on, children's survival rates go down. Okay? And then in panel B, when we look at by education, it seems to be that the women who typically use the hospitals most often are the ones who are most affected by these strikes. C and D, which you'll see in the next few slides, instead of whether or not there was a strike that occurred during the month of birth, we use instead how many days long was the strike during that month. And thinking about that a little bit more, this is a little bit weird to interpret because it says something about the intensity of the strike, but it also says something about our measurement error, right? So if there was a strike that lasted 30 days, that's a very intense strike, but it also means that I haven't misclassified somebody as being born during a strike when they really weren't. When a strike is 1 day long, it means that most of the kids born to that month I'm going to misclassify up here as being born during a strike, and also it was a short-lived strike. So there's some combination there. When we get to the slums data, it sort of clears up this days versus months dimension. But broadly speaking, I just want to say that even when we do it this way, we typically get the same pattern. More intense results for the high educated than the less educated than before.
So it's a huge effect, no?
Yeah, so great, exactly. So these are all large effects, massive effects. The standard errors are also large, so we don't rule out that there's not smaller, but even in some cases, they're not so large that there might not be a relatively large effect there. And that bothers us as well.
Because I also, this is the mean of the dependent variable,
Yeah.
but I assume that if you do the mean only for the high educated, it's going to be smaller, so the impact is even higher.
Right, right. So this bothers us as also. The only thing that makes us feel modestly better about it is that when we look at this slums data, when we have less measurement error, and it's also a separate data set and a kind of somewhat different population, we get the same exact size effects. So there's potentially these massive effects of not delivering in the place where you.
It might also be because it's quite close to zero anyway, so the linear probability model bites more.
Yeah. Yep. We could check that by doing it differently. That's right. This is suggestive. This is about height for age and weight for age. And what's important to remember here, this is conditional on surviving. Okay, so here we get these negative effects on height for age for weight and weight for age, not statistically significantly different from 0. But we do get kind of big effects for the low educated mothers. Now these aren't the ones who are having the mortality effects. But I think that kind of fits together. We're missing people from the high educated group that have died away, and that if they weren't dead, potentially would have had much lower height and weight for age, particularly weight for age. Is that more indicative of kind of ongoing health issues? Whereas the height for age, maybe you wouldn't expect anything to show up when these children are particularly young. But there's this idea of there's sort of selection going on here that we're selecting out potentially the least healthy of the high educated group. They've died off, and so we don't see them in the distribution. In fact, if you look at the two distributions, the women who have high education who are affected by the strike, that distribution actually shifts over a little bit to the right. They've lost people from the left-hand side of the tail. Yeah?
Just a quick comment too. I don't think these would be affected by delivering in a hospital or not, but more by the prenatal or postnatal.
Right.
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 So
Right,
it
exactly.
also fits in that way that it's not immediate mortality effect, but it's driven by the strikes that are happening before.
Exactly. So I switch whether I put this table after the next set or before. So I put it with kind of outcomes and then look at mechanisms, but exactly right. That there's some ongoing, the strike happens and then you didn't go to the hospital, and if you've had a child in a developed country, you know that when you go and deliver at a hospital, you get all sorts of information about what you're supposed to do next. And Kenya is actually no different. Well, I'll get to in a second, but one of the things that happens in Kenya when you're born is you get this card that tells you when you should get, what your vaccination schedule is. Thank you. And now that card is even more, gives you even more information, not just about vaccinations, but what you should do if you're HIV positive, what kind of food you should give your child. And so you get that information at the point of delivery. And I'll show you in 2 seconds, although I'm showing you now, that if you're born during a strike, you're much less likely to get that card. So even though, now I'll move back to where I should be. Okay, so the height for age, weight for age shows up mostly among the low educated. Okay. We don't see much change in where you give birth in terms of delivering at home, especially among the high educated. They end up being able to switch, but they're not getting, in some sense, this follow-on care. They're not potentially getting the health care they were supposed to get, or the facility they eventually went to when there was a strike was far away and they just don't feel like it's worth the effort to go there again, and so they never learn about what to do. So we don't see any change in whether the high educated give birth in a health facility or to go from a hospital, whether there's a doctor or nurse present. But as I mentioned earlier, these low educated ones who would have used the hospital, and potentially the ones who needed it the most, do switch to giving birth at home rather than at a health facility and don't get a doctor or nurse present. Okay, so because even though you're delivering at a facility, you're much less likely to have this health card. And then we see also you're much less likely to get vaccinations. The tuberculosis vaccine is at birth, and these two are after 6 weeks. That's the timing for that. And the measles is 9 months. So there's some wearing away and potentially of this kind of strike and then I don't go to the hospital effect. 9 months later, I'm just as likely to get this thing, a little negative coefficient here, but these ones that I needed right away, I'm not getting. And so we're putting that together with this story that potentially it's not just that the strike happens and you might not get care at that moment, but you don't get this set of follow-on interventions. So since I have a few minutes, I'll just skip to this, the slums data. But we include mother fixed effects, that was a good point, and we look at also distance to health facility using GPS coordinates, and we get the same pattern of results. So whether you split it by distance or high or low education. So this data from these two slums in Nairobi are quite close to some of the hospitals that have these major strikes. Is longitudinal data collected every 4 months from 2002 to 2012, where they ask people, did you give birth? What day? Did someone die? What day? Are you still living here? Did that person move? And income. And so we can match the exact date of birth to strike days, which cleans some things up. And it also has this really nice thing, which is a verbal autopsy of the cause of death. So we can look at exactly why did this child die. So these are the two slums, green. These red ones are striking hospitals. Green ones are private hospitals, and yellow are public. And I was looking at the map the other day. I think there's a few hospitals missing here. But you get the general sense that there's a lot of options. This is about 5 miles apart, so there's a lot of options in the area. But people are also close. This is the major maternity hospital in Nairobi, where people give birth. This is the large national hospital, and this is a children's hospital. And these are places where strikes occurred over this period. And so we get this same pattern of large effects on mortality if you were born during a strike. We don't split by high or low education here because we don't actually have that information. But these people are all close to these striking hospitals. And so we see the same very large effects relative to the mean. And the last thing we can look at is this cause of death. It seems to be largely driven by neonatal causes, which sort of makes sense. I mean, it's fortunate that it wasn't, accidents or something like that. It fits this story that complications that occur either at childbirth or shortly thereafter aren't being treated. So I'm not going to recap this, except to say we don't think a mechanism is particularly that people aren't going to hospitals. And when we set this out, at the beginning we thought, oh great, we'll have this instrument for whether you give birth at a facility or not. We don't have that. But we think that it's about this lower quality of care, whether they've switched to a hospital that's not preferred, or that they go to the same hospital, but it's working with a skeleton crew at the same time. And so this sort of supporting evidence is there's less follow-up care that we see going on. So this overall implies there's an important value to the usual health services being provided, at least in the places where women typically go, but that doesn't really mean that we should encourage all women to go to hospitals to deliver a child. Everywhere, besides just demand issues, what we're really looking at is at places where people typically deliver, which might have higher quality services to begin with. And we also don't look at the long-term benefits of strikes. These are very immediate, right? So it could be that a year down the road, a strike resolves positively, that the services actually increase and that there's positive effects of strikes. So we're not really thinking about strikes versus no strikes, but really just trying to capture this instantaneous value of the hospital. And we're not measuring other effects, positive or negative, of strikes on people who need other types of services, like you had an accident that day and what happened to you. So follow-up things is looking at, so there's sibling mortality information. We can look at mother mortality potentially. This slums data has these other modules on vaccinations we'd like to corroborate. They're just hard to get that data from them. We'd like to follow up with, and then maybe expand this to other countries, look at other places. Thanks very much.